everyone, and welcome to another episode of CCA's Medical Minute Podcast. It's sponsored by Kroger Health. I'm Sherry Hughes, and today we're going to be continuing our ASCO Direct Patient Perspective series. We're going to be kind of like drilling down on some of the important things that came out of ASCO, which is the American Society of Clinical Oncology. Joining me here in our studio is our very own Andy Guinigundo. He's our Director of Precision Oncology. And how you doing there, Andy?
I'm great.
I see you got your pink on, so that's
an indication,
pink on.
Right? We're talking breast cancer. So,
we are.
I was at ASCO this year in Chicago. I actually saw this presented, so I'm excited to talk about it.
I'm excited too, and we're going to bring on a guest today, and she is coming to us from Providence, Rhode Island. Dr. Steffi Graff, Director of Breast Oncology at Lifespan Cancer Institute. Hello, Dr. Graff.
Hello, thanks for having me.
Thank you for being here. Before we get started talking about some of the things that came out of ASCO this June that are really big, I have to say, you were named Woman Disruptor of the Year last year.
I love that.
At ASCO.
I love that.
So that means, you are challenging things, you are inspiring, you are educating, and you are on the cutting edge of making sure that information about breast oncology gets out there. And so that's why we wanted to have you here on the program today.
Yeah, I came home with that honor, and my husband asked me if being disruptive was a good thing. And I said, maybe not for him, but in the greater oncology landscape, yes. So it was an honor.
Well, thank you so much for being here. And Andy and I were talking. He was at ASCO, as he said, as well. And that's the largest cancer oncology conference in the world. And so, Andy, there were some big things coming out of ASCO. And so that's why we want to bring Dr. Graff in.
For sure. Yeah, no, I mean, really every cancer they talked about. I frankly have never been to a meeting that big, and it's a little bit overwhelming, but yet it really feels like you're on the cutting edge. It's a little bit difficult, even as a nurse practitioner, to kind of absorb everything, and even as a physician, really to absorb everything. But our job today is to kind of boil it down to the patient level. What can they take out of what came out of ASCO that they might be seeing, in their doctor's offices in the years to come?
Exactly. So, Dr. Graff, what, in your opinion, would be the biggest thing in terms of breast oncology that came out of ASCO this past June? I mean, I know there were lots of nuggets there, but one of the largest things that impressed you.
Yeah, I think it's always hard to choose, but what I recommended that we talk about today was the NATALEE trial. NATALEE's full name is ribociclib and endocrine therapy for adjuvant treatment for patients with early stage hormone receptor positive, HER2 negative breast cancer, primary results from the phase 3 trial.
Wow, that's a lot. So we're going to boil that on down. We know that one of the major components of that particular study was with Ascali, right? Cascali. And so tell people at home, in a nutshell, what did that study bring forth?
Yeah, so I think that the key messages for an at-home audience is that we've known for a long time that most early stage breast cancer is hormone receptor positive, meaning it's growing because of estrogen and progesterone. And that if we block that, gasoline from the fire, if you will, that it's less likely for a patient's cancer to come back in the form of metastatic disease down the road. And so Kisqali is the brand name, ribociclib is the generic name, is what we call a CDK4/6 inhibitor. What I say to my patients is that, if you consider estrogen the interstate, CDK4/6 is the detour route. And so if you block both, you get one heck of a traffic jam, right? We've all been in that traffic jam. And so by blocking both of those, we really dramatically decrease the risk that cancer can come back. And so we already have one CDK4/6 inhibitor called abemaciclib or Verzenio approved for early stage hormone receptor positive breast cancer, but it's only approved for the highest risk patients with a whole bunch of positive lymph nodes. The NATALEE trial took patients even with lymph node negative breast cancer and asked if adding that medicine in addition to the traditional hormone blockers we use can help improve outcome. And the results were good.
Mm-hmm.
That's great. So this trial, it included both people who had chemotherapy ahead of time and people who didn't need chemotherapy. Is that correct?
Technically, yes, although the vast majority of patients that were eligible or who participated had received chemotherapy before. Again, just because this is trying to increase outcomes in a high-risk population, most of the patients, even the lymph node negative patients, are patients that had been selected for chemotherapy.
Okay.
So, Dr. Graff, the study pretty much supports the PFS, or progressive-free survival, as well as the OS, which would be the overall survival, with patients that were part of that study. Is that correct?
Yeah, the overall survival data isn't mature yet, which means we just need to watch for a longer time before we can say definitely, but it looked like it was going in that direction. The progression-free survival means that the patients that received the ribociclib, the Kisqali, were less likely to have evidence that their cancer had come back. Understandably, even when patients' cancer comes back, we still have a wealth of options for cancer treatment for them, which is why we have seen an improvement in progression-free survival, but not yet overall survival, because even for the patients whose cancers have come back, there's still lots we can do to help those patients.
Mm-hmm. So one of the things that I like to look at in terms of thinking of this entire thing is that we saw advanced type patients, as well as metastatic patients that were actually already benefiting from Kisqali, correct? But now the question came out of that, like, okay, if they're benefiting from this, then we ought to look at some of the earlier stage cancer patients to see how this could help them in the long run as well.
Yeah, that's exactly right. So we've been using these CDK4/6 inhibitors, medicines like Kisqali, Verzenio, Ibrance, for a very long time to treat metastatic breast cancer. We know that they're safe. We know that they are very well tolerated. We know that patients do great with those medications. I think that as cancer experts, we're all very comfortable managing the side effects and managing them. They're just pills, so patients can take them at home. They don't necessarily have to come into the clinic for infusions or anything like that. And so it's just one more way that we can help improve the outcomes for patients diagnosed with this disease.
So patients who are at that juncture of their treatment and they meet the profile that that long title that you read, if they show up at their oncologist office today, would they be offered this? Is it ready to go? I mean, is it ready for prime time?
Yeah, so I think that's our biggest barrier, is that we're still waiting on regulatory approval. So we're still waiting for agencies like the FDA, the Food and Drug Administration, to say that this is ready to prescribe in this situation. Again, we do already have abemaciclib or Verzenio approved for patients with significant lymph node involvement. For patients with lymph node negative or less lymph node involvement, 1 or 2 or 3 positive lymph nodes, we're still waiting to find out if this ribociclib Kisqali medicine is approved in that setting. I think, in the United States, we're lucky in that most patients are doing screening mammograms. So most patients are diagnosed with breast cancer in its earliest stages. It's pretty unusual to find breast cancer with 20 or 30 positive lymph nodes. Normally, even in lymph node positive breast cancer, we find a pretty small number of positive lymph nodes because we detect cancer with screening in the US. But that doesn't necessarily mean that it's not an aggressive behaving cancer. And so this trial, this data really helps us look beyond just stage and address biology and treat the cancer and the way it's behaving by using some other predictors for who might benefit from these medicines.
And Dr. Graff, I am a breast cancer survivor. I'm coming up on 4 years here, July 30th at the end of the month. Woohoo! My pathology, though, was HR negative and HER2 positive. So this is not something that someone in my category would benefit from. There are other types of medications for that, I believe, but for someone else that is going through, as you said, a specific type of HER2 negative, if you will, scenario.
Yeah, so there's three kind of main subtypes of breast cancer. That's a great point. Hormone receptor positive or estrogen receptor positive is the largest group. And then the other two types of breast cancer are HER2 positive, which is what it sounds like you had.
Yes.
Patients with HER2 positive typically get treatment specifically targeted at HER2. And then there is a third subtype called triple negative, which is called that because it's negative for estrogen and progesterone and HER2. So it's really defined by what it's not rather than what it is.
Yes.
And those patients now can actually get immunotherapy as well to target their cancers.
Dr. Graff, Andy and I were in the office yesterday kind of going over some of this. And one of the things that we thought of is, does this change the paradigm for chemotherapy as we know it now for, these patients looking at this particular study? Andy, you were mentioning.
Yeah, no, we were talking about really kind of brainstorming into the future. Is this something that perhaps that studies might be looking at moving it even earlier in the game? And, like in metastatic setting, we don't touch that chemo first. We're picking up those CDK4/6s first, not chemotherapy first. Might that happen in earlier stage breast cancer? I'm not holding you to anything, but
hey,
we're just disrupting.
We're looking into the future here.
Yeah. I love the disruption. I do think that is one of the future directions is as the data gets more mature for CDK4/6 inhibitors in early stage breast cancer, if we can predict the quote unquote super responders, the patients that really seem to get maximal benefit from adding these medicines, are those patients that then can skip the chemotherapy part to really get a better outcome or a better outcome with less side effects. The other question on how this is really going to shake things up is if we start using these medications, the CDK4/6 inhibitors like Kisqali or Verzenio, for the treatment of early stage disease, in the unfortunate situation where cancer comes back anyway. These medicines have been our standard in advanced stage disease. Luckily, there's lots of new medicines, including the antibody drug conjugates, which I know was a big topic across all of ASCO, and I'm sure other guests are going to be talking about in earlier stages of disease. So we'll be shaking up what sequence we use all of these medicines.
You mentioned, and Andy has mentioned this as well, the CD4/6s. And when I think of that, that's that bad stuff that's right in the core of the actual cell, right? That has the ability to take that cancer cell and replicate it and make it grow. So this particular study is introducing the methodology of a way to hold that at bay. Is that correct?
Yeah, the traffic jam that she was talking about.
It stops that proliferation or cell turnover, which is the bad thing that we don't want our cancers to be doing.
Mm-hmm. And so that brought me to how long, when you see that it creates this traffic jam, it creates some blockages. How long can you benefit from something like that before cancer tends to be one of those things that wants to just find ways out of no way to survive, right, and do the damage. But how long would we be looking at this being a benefit?
Oh my gosh, Sherry, that's such a great question. So that is one of the big questions in oncology. The trial using abemaciclib or Verzenio, which was called the Monarch-E study, patients took these medicines for 2 years. The NATALEE trial, the one we're talking about right now, using Kisqali or ribociclib, patients took these medicines for 3 years. And so going back to my traffic jam analogy, the question is, how long can your car run on that tank of gas or the fumes in your tank of gas? If you're blocking all the estrogen for your tumor, how long do you need to do that before those cells starve to death? And so we've seen one drug chose 2 years and one drug chose 3 years. And hopefully as this data matures over time, we'll get a clearer answer on what the right pathway is. But we've changed our minds a little bit on the broader breast cancer landscape. We used to give medicines like tamoxifen or Arimidex and anastrozole for 5 years, and increasingly we're recommending them for longer, 8 to 10 years. And so, there's a chance that this will be another thing that is in constant evolution as we learn.
Evolution, yeah, I like that word, because actually this whole study is because of the evolution of finding that advanced breast cancer and metastatic showed that it was, being held down and held at bay. And so this is one of those studies that helps to create yet something for someone else that's out there in an earlier stage fighting.
Yeah, for sure.
Which is such a great reason to participate in clinical trials is, even every clinical trial that a patient volunteers to participate in doesn't just potentially help them, but it helps generations of cancer patients that come beyond them as we fine tune how to use this medication in other stages of disease, earlier lines of therapy, better select and identify who benefits. And we're constantly learning, which is amazing.
So if a patient goes into her oncologist's office and say, hey, I've heard about this Kisqali and I've heard that, maybe I should be taking this. What then would you say to patients that might be listening to us? Because this is a patient perspective today when they hear some of this kind of information.
I think it's a great time to start the conversation with your physician. If you had estrogen receptor positive early stage breast cancer, about whether or not this is a medicine that you could have added to your treatment or might be an appropriate treatment in the future. In this trial and in the follow-up study that's already being planned called WIDER, patients were able to start taking this medicine up to a year after their diagnosis. So even if you just recently finished your treatment or are already on your anastrozole or tamoxifen, this might be something that's still appropriate, even though we don't have approval today. If we get approval in October, for example, maybe you can call your doctor and start then. And so gathering up information, deciding if it's right for you, are all good conversations to have early and often with the doctor taking care of you.
Yeah, I was going to say one of the big pushes with ASCO, just in general for research protocols, is really recruiting a diverse population of patients. I noticed that the guys were not left out on this trial, so that's good stuff to know that you can generalize that.
Male breast cancer is a really important demographic group that we always want to include in clinical research. And, male breast cancer has some unique features in terms of how the hormonal cascade works for men with breast cancer. Definitely still eligible for this study, eligible for this medication, a group that we should include. Similarly, all demographic groups, elderly patients, Black women, Latinx community, everybody that we are thinking about are groups that we should be talking about whether or not we want to be considering adding additional therapy to improve their outcomes.
Well, thank you so much, Dr. Graff. Is there anything that we didn't mention that you really want to get out there about this particular NATALEE study?
No, I think this has been a great conversation. I would just encourage patients to always be comfortable asking their doctor questions. That's what we're all there for. That's what brought us to this field, is that we love engaging in conversation with our patients. So don't be afraid to say, hey, I heard this thing and I want to ask you some questions about it. I know they'll look forward to having the conversation.
Thank you so much, Dr. Graff, and please keep on disrupting. Keep on upping the game, as they say, and challenging those out there, because we need that in terms of, all cancers, but breast cancer, of course, being that 1 in 8 women are diagnosed in their lifetime. And it is, such a pervasive and prevalent disease.
Perfect. Thank you for having me.
Thank you.
Thank you very much. And thank you all for joining us on this episode of Medical Minute. Please like, share, and subscribe, and we will see you again the next time. Until then, take care.